So stating that we saw in the video, we can easily understand that ERCP, tissue acquisition in strictures, is a very, very challenging technique. And we have to optimize this procedure using the best device to try to obtain a correct diagnosis. Cecilia, could you explain us some tricks about brushing technique?
So let's move into technical detail of brushing technique. To date, there are no consensus on how to perform ERCP-based brushing. Usually, the brushing is passed through the stricture with back and forth movement at least 10 times. However, it's quite obvious that improving the amount of tissue acquired could improve again the possibility to gain cancer detection. So some studies suggested also to have to perform 2 brushing into the same strictures with the same number of back and forth movements. However, recently, Wang and colleague demonstrate that increasing the number of passes through the strictures lead to a better sensitivity of brushing cytologies. Indeed, 443 patients were randomly assigned to receive 10, 20, or 30 brushing times of pass. The sensitivity of brush cytology was 38%, 47%, and 57% respectively. And the 30 times group shows significantly higher sensitivity than the 10 times group, without a significant difference in adverse event rates. The multivariate analysis revealed the stricture length and the number of brushing passes were significant factors to the detection of biliary malignancy. So, standing to this study, performing at least 30 passes of brushing through the stricture, it's a safe and cost-effective option to improve the accuracy and the detection of malignancy with brushing cytology.
Thank you, Cecilia. Very interesting data. We have to stress that tissue acquisition is a very, very challenging procedure in this sort of strictures. And we have to ask in our hospital to utilize, to improve, to create a multidisciplinary approach. And I would like to ask to Chiara if there is some tricks that we can apply to optimize tissue acquisition.
Yes. First of all, a correct preparation of the slides is mandatory, and to do that, it is crucial to involve the pathologists, especially during the first times, in order to adequately train both endoscopists and nurses to do it. A second point is that it could be necessary to send for cytological examination not only the slides but also the tip of the brushing, in which it could be found a not negligible amount of captured cells. Not least, rapid on-site evaluation, it could be useful to improve the diagnostic yield of brushing. Recently, an Italian retrospective study reported that the diagnostic yield of ERCP-guided brushing of biliary strictures, when supported by rows, had a sensitivity far higher than those reported for brushing alone, and at least comparable to those of more expensive techniques.
Good point. But we know that the pathologist is present only in 30% of cases. And that means that we have to create multidisciplinary discussion in our hospital. And I want to include in this conversation Adele Fornelli. Is it only a matter of tools?
Many reasons can explain the low sensitivity of biliary cytology, and they concern all the phases of the pathological examination, the pre-analytical, the analytical, and the post-analytical phase. Regarding the pre-analytical phase, we have to remember that cholangiocarcinomas, which are the most common malignant tumors causing biliary strictures, tend to grow underneath the mucosa, which can be ulcerated, and thus leaving very few amounts of epithelial cells when subjected to brushings. And so the proposal of Wang and colleagues, as Cecilia reminded us, is really useful in improving the sensitivity of this text. And also the preparation of the slides, as Chiara pointed out, is mandatory. First of all, the brush must be opened carefully outside the sheet, and the retrieval of the material must be done immediately. The brush has to be put onto a glass slide, and then the material that will be detached from the brush has to be smeared onto several slides that have to be fixed immediately in alcohol. And after that, the brush is cut from the tip of the catheter and is placed in a plastic tube. The plastic tube contains a fixative alcohol or cytolite, depending on the techniques that are available in your pathology lab. And in the pathology lab, the plastic tube is agitated in order to dislodge any residual tissue that is entrapped among the bristles. And this tissue will be processed as cell block or thin prep. And then regarding the analytical and the post-analytical phase, I have to admit, as pathologist, that biliary cytology is a very difficult task, because we frequently see reactive epithelial atypia that is a very great mimicker of malignancy. And reactive atypia is very frequent because of lithiasis or indwelling prostasis. And so, what to do? The pathologist can ask for more tissues, such as endobiliary biopsy, that can be obeyed if it contains invasive foci, or can ask for ancillary techniques, such as FISH or NGS PCR, that can identify gene mutations. But these techniques are rather expensive, and they are not available in every lab. And in addition, if cytology is suspicious for malignancy, finding gene mutations can be helpful. But what to do if cytology is negative and gene mutations are present? I think it's too early to rely only on molecular findings. Another way to overcome the difficulty can be seek help from an expert cytopathologist. And this can be done using digital technologies, which are available quite in every lab, or to become a dedicated pathologist. And to do this, I advise to go to the procedure room and to assist all the procedure. This is very, very useful. And in this context, I'm also aware of the paper by Archibugi and colleagues regarding ROSE on ERCP material. Of course, it is a very effective method, but in the long period it can be very expensive and time-consuming for the pathologist. Anyway, I'm sure that ROSE or the presence of the pathologist on site in the procedure room can remove all the criticism regarding the pre-analytical phase. But of course, we have to stay here in the lab and make a lot of diagnosis. So in the long period, it's not so easy to do.
Thank you, Adele. I would like to mention another point. And I would like to discuss with Chiara and Cecilia. What about the use of forceps? Because we know that transpapillary biopsy is very challenging and is not in routine clinical practice. What is your point of view?
Yes, as for brushing, it is to date non-standardized how to perform a transpapillary biliary biopsy forceps. It is considered a safe and simple procedure. However, as we saw in the video, the diagnostic yield of this procedure is still suboptimal, and data to date are sparse regarding the number of passes needed in order to optimize the diagnostic yield of this technique and achieve a diagnosis of malignancy.
A recent retrospective study performed in South Korea investigated factors that could affect the diagnostic yield of transpapillary biliary forceps biopsy in a cohort of 376 patients affected by biliary strictures. In this study, authors concluded that bile duct cancer, intraductal growing type, and 5 or more tissue samples were significant predictors of positive biopsy results, and that increasing the number of tissue samples by 5 or more led to higher sensitivity in bile duct cancer with infiltrated periductal type.
Yes, however, it is known that performing such a number of passing and achieving such an amount of tissue samples with forceps biopsy is technically challenged and not always feasible. So having probably a wide-guided forceps could be very useful in this setting. And we also have to know that some studies propose the use of a small catheter in which a small forceps biopsy is inserted through in order to target the biopsy and safely perform a high number of passes, especially for hilar or intraductal biliary stenosis.
So, trying to provide some take-home messages, in case of biliary stricture, it's still important to improve the amount of tissue for cytological and histological examination. For brushing, probably 30 passes through the stricture are needed, while in case of transpapillary biliary forceps biopsy, 5 tissue samples are suggested. However, in order to optimize the sensitivity, the combination of both the technique is still suggested, and when available, the use of fish and DNA methylation is mandatory. Thank you.